myocarditis, multiparametric approach. No disclosure. And as we know, myocarditis is characterized by myocyte necrosis and inflammatory cell infiltrates. It has a different etiology. Among them, the virus is most common one. We have seen most of the cases of the myocarditis after COVID, and about most of the patients of myocarditis recover within few months, but about 12 to 25% of the patient develop in persistent cardiac dysfunction or may progress to dilated cardiomyopathy. And mortality is seen in 20% and is more common in younger age group. So the diagnosis of myocarditis is quite challenging because of its diverse etiology, because of heterogeneous manifestations, and other possible mimickers. And cardiac MR is considered as the non-invasive gold standard method for the diagnosis of myocarditis, because it helps in evaluation of myocardial function and tissue characteristics. It helps in diagnosis and risk stratification of patients with suspected myocarditis. And cardiac MR is considered as a gold standard in non-invasive, whereas in invasive, it is always an endomyocardial biopsy. So the important sequences that we need to perform when we suspect a case of myocarditis is seen a steady state free precision, and most of us prefer is to tell is a golden sequence that help in evaluations of functions and wall motion abnormalities. And other important sequences are T-twister, gadolinium enhancement, T2 and T1 mapping, from which we can calculate an extracellular volume. So what is the important criteria that help in a diagnosis of myocarditis in more precise way and which more easy way, which has a high specificity and positive predictive value? That is the Lake-Lewis criteria, and it has been updated in 2018. Previously in 2009, only the T2 early gadolinium and late gadolinium enhancement has been included on it. However, in 2018, T1 and T2 mapping has been included, and it helps in easy way to the diagnosis of the myocarditis. So taking an myocardial edema as one, if we see an elevation of T2 relaxation time or regional or global elevation or hyperintensity in the wall of the myocardium is the one that includes a myocardial edema. In non-ischemic myocardial injury, if there is a regional or global elevation in native T1 relaxation time or elevation of extracellular volume or regional enhancement of the left ventricular myocardium. And if we so from the myocardial edema, one criteria from the myocardial edema and one criteria from non-ischemic myocardial injury, it fulfills the criteria for the diagnosis of the myocarditis. So going on a specific sequences with its importance, T2 hyperintensity. If we see and T2 hyperintensity that reflect towards the myocardial edema. Here in this case, this is a short axis view image where we can see the right ventricle and the left ventricle that shows a hyperintense signal in the lateral wall of the left ventricular myocardium. And next important one is late gadolinium enhancement that assess the fibrosis and the necrosis. And we see the non-ischemic pattern of the enhancement or involvement in case of myocarditis, that is the soft epicardial or mid myocardial enhancement. So this is again the short axis view image after the gadolinium that is taken 15 minutes after the gadolinium, and we can see the enhancement, that is the mid myocardial enhancement in the lateral wall of the myocardium of the left ventricle. So this is the images that show the different pattern of enhancement. The epicardial and the mesocardial enhancement is seen in the case of myocarditis, also can be seen in other cases like Anderson and Chagas disease, and whereas the subendocardial and transmural enhancement is seen in case of coronary artery disease, amyloidosis and so on, and the patchy enhancement is seen in case of sarcoidosis. So with this only two sequences, diagnosis of myocarditis is not that worth. So we need to do mapping, and it is updated now. And in mapping, the first one is T1 mapping. The value of the T1 relaxation time depends upon the strength of the MRI. It is different for 1.5 Tesla, 3 Tesla and so on. And the value of T1 relaxation time is elevated in case of myocarditis, that can be more than 1090 and above in case of 1.5 Tesla, and in case of 3 Tesla it can be more than 13,000 millisecond, and the elevations can be seen in case of amyloidosis as well. And this is a case of the myocarditis where we can see the elevations of the T1 relaxation time, that is 1391 millisecond. And another one is extracellular volume that we have to calculate from the pre and post contrast T1 mapping. Extracellular volume is a quantification of the fibrosis, and it is an independent predictor of adverse cardiovascular event, and it is alone not is for the diagnosis purpose, but it assess and predicts the adverse cardiovascular event. And extracellular volume, if it is elevated, that is more than 35%, and it is a predictor for the major adverse cardiovascular event. And the ECV, here in this case we can see the ECV of 43%, that is a case of an myocarditis with predictions of major adverse cardiovascular event. And this is the normal range. Next is the T2 mapping. The normal range of the T2 mapping again depend upon the strength of the MRI, and T2 mapping detects the myocardial water content, that is the edema. And here you can see the elevated T2 relaxation time, that is the 60 millisecond, which can be seen in case of myocarditis again. So going on with some of the cases of the myocarditis that we encounter in our institute, and this is the case. The patient presented with the history of acute chest pain, and she has an elevated troponin level, but her ECG and echo were not that of significant, and coronary angio was done and it was found to be normal. And again patient came to us with to perform a cardiac MRI, and we have seen an hyperintense signal intensity in the lateral wall of the myocardium with enhancement, that is mid-myocardial subepicardial enhancement in the lateral wall. And on T1 and T2 mapping, we have seen an elevated T1 value, that is 1350 millisecond, and T2 value, that is 62 millisecond, with an elevated extracellular volume. And this is a typical case for myocarditis. And again, this is another case. Male patient at his 50s, and I think this he presented with the just with a mild chest pain, and cardiologist saw and just a minimal wall motion abnormalities, and he indicated him for the cardiac MRI, and we didn't see any enhancement in the post contrast. But when we did a mapping, we saw an elevated T1 and T2 value on this patient. So only on the basis of the enhancement, the diagnosis of myocarditis is not that easy. We have to do mapping for the diagnosis. And we suspected this as a case of the myocarditis, and we kept this patient for the follow-up. After the 3 months of the follow-up, this patient, when we did a mapping, and the value of the T1 and the T2 are found to be in decrease, and the patient's symptoms has been almost recovered. So this is a case of myocarditis that has been diagnosed with a mapping rather than the enhancement. So again, this is a case where the cardiologist sent us like suspecting a case of myocarditis, but the case came out as a pericarditis later on, and we can see the pericardial effusion, and this is the late guided in a sequence where we can see the enhancement in the lateral wall. I'm talking the most of the cases with the lateral wall enhancement, because the enhancement in case of myocarditis is more common in the lateral wall, and we have seen most of the cases of lateral wall enhancement rather than in the anterior and the septal enhancement. And we did again a mapping in this case, and we didn't find any elevation of the T1, T2 value and ACV. So we saw a mild pericardial thickening with pericardial effusion and without elevation of the T1 and T2 value, and we diagnosed it as a case of pericarditis rather than that of myocarditis. So going on a AI, which we can't skip, it is particularly beneficial, and nowadays texture analysis is used in radiomics that provide a potential for automated myocarditis imaging, and it increases in precision in a diagnosis and assessment of prognosis. So what's the prognosis of the myocarditis? So it depends upon the extent of late gadolinium enhancement, how much percentage it is involving, depending upon the volume of the myocardial mass. So more the percentage of the involvement, worse is the diagnosis. And next is the persistence of late gadolinium enhancement. Not only in how much percentage, but how much time it is persistent. If we keep the patient follow up in 3-month interval. If the patient still have the persistent late gadolinium enhancement or if it is increase in value of the if it is there is increase in percentage and if it is increase in percentage and there is stable late gadolinium enhancement, then it is a case of worse prognosis. And next is the T1 and T2 mapping value. This also plays an important role in the prognosis of the case with myocarditis. And ECV, I have already told, if the ECV value is greater than 35%, then that patient is with the chance of major adverse cardiovascular event like arrhythmia, heart failure, and so on. And again, the extent parameter has been also placed like global longitudinal strain, global circumferential strain has been placed as a criteria for prediction of the prognosis in case of myocarditis. So follow-up. Follow-up is must at a 3-month interval in case of myocarditis as it reduces the risk of sudden cardiac death and arrhythmia, and sport clearance is a must in the case in which we diagnose myocarditis. And it helps in identification of persistent of high-risk late gadolinium extent and residual inflammations. So I am going with some of the case of myocarditis follow-up. This I have taken from the internet, and this is a case which has been diagnosed with a myocarditis with all the elevated, like we can see the hyperintensity inferior wall, and we can see the late gadolinium enhancement with elevated value, that is the percentage of late gadolinium enhancement, that is 5.9%, and the patient has been kept for the follow-up, and we can see there is an almost gone hyperintensity in a T2 with a decrease in T1 relaxation time, with the late gadolinium enhancement has been decreased in comparison to baseline MRI. And this patient has been advised to, he is a sportsman, he was a sportsman and he was advised to go back to his sports competitions. And again we did a follow, again this case has been done follow-up in after 18 months, and he didn't fail any major cardiovascular event in this scenario. But this is another case, that is 30 years old male that presented with the suspected case of myocarditis with elevated all value in the baseline MRI, and this was a case where the late gadolinium enhancement has been decreased but not that of significant value. It was 18 and it is again 8.4% after this this MRI has been done after 6 weeks because the patient presented with symptoms of heart failure and it has not that been decreased. So this patient suffered from the major adverse cardiovascular event. So this is why late gadolinium enhancement is one of the prognostic factor in case of an myocarditis. So these are the take-home messages. As a multiparametric cardiac MR is a non-invasive evaluation of myocardial function and tissue characteristics, and we have known about the updated Lake-Lewis criteria for the diagnosis of myocarditis, and patient with increased baseline LGE mass has a worse prognosis, and follow-up at a scan at a 3-month interval are the must after initial diagnosis. And these are my references, and thank you everyone.